Hello, my name is Wendy Adams. I'm an assistant laboratory director at NMS Labs in Pennsylvania. I'm talking to you today about the new relevance of hydroxychloroquine and chloroquine in forensic toxicology. First, I'd like to disclose that I am a paid employee of NMS Labs, a commercial provider of toxicology and other forensic testing services. I have no conflicts of interest to disclose. So I thought this topic would be of interest to forensic toxicologists and perhaps other forensic scientists because hydroxychloroquine and chloroquine have been featured in the news recently. Beginning in early March, on the 4th of March, chloroquine was added to COVID-19 treatment guidelines in China based on multi-center clinical trials. However, they did note in the clinical trial publication that chloroquine should not be used in patients with heart disease. Quickly after that, the World Health Organization included chloroquine and hydroxychloroquine in international Solidarity clinical trial to treat COVID-19. The following day, President Trump referred to hydroxychloroquine as a game changer in the fight against the COVID-19 pandemic. Shortly after that, the Food and Drug Administration authorized emergency use of chloroquine and hydroxychloroquine for the treatment of COVID-19. Following all of this, there have been reports of toxicity related to these two compounds. On April 9th, the American Association of Poison Control Centers issued a statement that hydroxychloroquine exposures had doubled compared to the same 2-week period in 2019, from a total of 35 to 76. And also on March 22nd, it was reported that a couple in Arizona drank chloroquine phosphate algaecide that they had mixed with juice in an effort to prevent symptoms and onset of COVID-19. Following the ingestion, they were both sickened and hospitalized. One of the patients died from cardiac effects. In the interest of talking about these drugs in a context of forensic toxicology, I'll begin by discussing their adverse effects, followed by beneficial effects. Of course, they are two sides of the same coin. I'm starting with the adverse effects because that's the most important part to toxicology. I'll also speak briefly about pharmacokinetic concerns for interpreting blood and other body fluid concentrations, and some risk factors for toxicity. So to get started with the good, the bad, and the ugly effects, let's talk about the mechanism of action of this class of drugs. It begins with quinine, a substance that was extracted from cinchona bark in Peru. And it was used in India and Sri Lanka by the British Empire as a tonic to prevent malaria. It was a very economical treatment. It's also the bitter agent that's added to tonic water. There are two other molecules used as drugs based on the same 4-aminoquinoline structure as quinine. They are chloroquine, which came first, and hydroxychloroquine, adding a hydroxy group to the chloroquine molecule. I called this slide the Law of Unintended Consequences. These drugs have diverse mechanisms of action. They act on many different sites inside of the cell and the body. And because of that, they can have a variety of different effects, both good and bad. So first of all, there's the structural similarity to the prostaglandins and cytokines, which allow these molecules to inhibit the enzymes in the inflammatory cascade. They are also charged molecules, and this feature allows them to accumulate in lysosomes, which is particularly important to their treatment of malaria. They also inhibit endosomes that are involved in transport in the cell. And this feature is also the reason that they bind to melanin, which will become important when we talk about retinopathy as a side effect. A third mechanism of action is their ability to block the pore of potassium channels. And the picture at the bottom of the slide shows the hydroxychloroquine molecule docked inside of an inwardly rectifying potassium channel. So it effectively plugs that hole and prevents potassium from passing through. Finally, hydroxychloroquine and chloroquine both act as zinc ionophores. So they can shepherd zinc molecules within the cell. Zinc is an important component of RNA replication, and the ionophore feature allows these molecules to inhibit RNA replication. So of course, this would slow the division replication of the virus. This is a summary of the different mechanisms of action and how they are both responsible for adverse effects and beneficial effects. So first being the prostaglandin synthesis. If you inhibit prostaglandin synthesis, you can cause immunosuppression, which might not be a good thing if you want system actions. However, this also has a beneficial effect, anti-inflammatory. And this is the reason inhibiting prostaglandin synthesis is inhibiting thromboxane, which is primarily involved in clotting. So hydroxychloroquine has anticoagulant functions. The second mechanism, the increased pH of lysosomes, contributes to the adverse effect of retinopathy. In this case, it inhibits transporters in the retinal pigment epithelium, and it accumulates in the eye and can cause death of those cells. However, it's also a beneficial effect because this is what gives it its ability to fight malaria. And also, because it stops transport across cell membranes, hydroxychloroquine and chloroquine have both been investigated to be combined with chemotherapeutics because they help to reduce resistance that cancer cells have by ejecting the chemotherapeutics from inside the cell. The third mechanism of action, blocking potassium channels, seems to contribute to the cardiac toxicity of these drugs, including contributing to hypokalemia as well as arrhythmia. Finally, the zinc ionophore disrupts, so the beneficial effect of that is that these drugs can act as antivirals. However, they cause damage to rapidly tissues that need similar zinc finger domains in order to replicate DNA. And that can be effects seen primarily in the GI tract, gastrointestinal tract, as well as bone marrow. I'm going to talk in detail about each of the adverse effects of hydroxychloroquine and chloroquine. First, cardiovascular effects. The main feature of hydroxychloroquine and chloroquine is that they can increase the QT interval. This is thought to be mediated by the hypokalemia that they cause. The longer QT interval can contribute to arrhythmias and increase risk of arrhythmic mortality. Second, blood dyscrasias. This is a known adverse hydroxychloroquine and chloroquine as well. It's because of the zinc ionophore that impairs RNA and DNA replication and can cause bone marrow failure. Some different blood dyscrasias reported after using these compounds include aplastic anemia, agranulocytosis, leukopenia, and thrombocytopenia. It's particularly important to note that individuals who already have a genetic disposition towards aplastic anemia with glucose 6-phosphate dehydrogenase deficiency are contraindicated for using hydrochloroquine and chloroquine. First effect is retinopathy, and similar effects have also been seen with hearing loss and bleaching of hair. Because hydroxychloroquine and chloroquine bind to melanin, they're likely to interact and sequester with melanin-containing tissues, including the choroid of the eye. They cause damage to these cells, usually around the macula, which can cause irreversible blindness. They induce vacuole formation through their lysosomal pH altering ability, and that results in cell lysis and retinal death. For this reason, a maximum dosage of 5 milligrams per kilogram daily has been recommended for hydroxychloroquine. Next are adverse effects in the central nervous system. These drugs have been shown to lower the seizure threshold. The mechanism is not well characterized. However, it does appear to be related to inhibition of GABAergic signals. And GABAergic is the primary depressant in the central nervous system. So inhibition of GABAergic neurotransmission would tend to be excitatory, thus contributing to the risk of seizures. Other additional adverse effects in the central nervous system can include dizziness, ataxia, muscular weakness, and tremors. Also, psychiatric adverse effects include nervousness, irritability, and psychosis, nightmares, and even suicidal behavior. Among the adverse effects of hydroxychloroquine and chloroquine are multiple drugs. So there are interactions, different drugs used to treat heart disease. Important to note, amiodarone, an increased risk of arrhythmia if hydroxychloroquine is combined with amiodarone, as well as with any other drug that could lengthen the QT interval. Also, increased plasma cyclosporine levels were reported when hydroxychloroquine was co-administered. The tendency for hydroxychloroquine and chloroquine to cause hypoglycemia could mean a dose adjustment is warranted for insulin or other hypoglycemic drugs. And finally, there are different effects of acids on chloroquine concentrations, so they might not be able to be taken together. Here are some details about hypoglycemia that's caused by hydroxychloroquine and chloroquine. It's rarely severe, but it has been reported even in non-diabetic patients. Ethanol consumption is a risk factor for this type of hypoglycemia. The drugs inhibit insulin metabolism, which causes increased concentrations of insulin in the blood, and therefore promoted glucose transport into the cells. Overall, the blood concentration of glucose is depleted, and the brain experiences this as hypoglycemia, which can cause dizziness and weakness. There's also a beneficial effect, though, because diabetic patients will actually have improved glycemic control while they're taking these drugs. There are 4 main risk factors for toxicity in chloroquine. The first are individuals with glucose 6-phosphate dehydrogenase deficiency of hemolytic anemia. The second are patients with liver disease. Caution should be used in patients with hepatic disease, alcoholism, or hepatotoxic drugs. And this is primarily due to combined toxic effects on the liver, such as cardiomyopathy, epilepsy, and diabetes. Will need careful consideration when using hydroxychloroquine and chloroquine. And there are some age groups that are particularly vulnerable to these drugs. For example, chloroquine has been shown to cause birth defects in animals. Infants and children are noted to be extremely sensitive to the toxic effects of all 4 aminoquinolones. And geriatric patients may have impaired excretion due to reduced renal function. Now the other side of the coin. So any substance that produces effects, whether they be adverse or beneficial, can also produce the opposite side of the coin. The beneficial effects also have a variety of mechanisms that they use, targeting lysosomes being the original and older mechanism of action. 4 aminoquinolones accumulate in lysosomes, becoming charged in the acidic environment. And this prevents them from diffusing out. So they accumulate in that lysosome, change the pH of it, and can cause swelling or malfunction of the organ. This makes them toxic to Plasmodium parasites, which is a great benefit for treating malaria. They also inhibit notable enzyme function, including the MHC class II antigen presentation on monocytes. Because they selectively inhibit presentation of self-antigens. They're very useful for the treatment of autoimmune, in particular, systemic lupus erythematosus. Lysosomes is also a mechanism of action related to antiviral properties of hydroxychloroquine and chloroquine. Because they increase the pH of lysosomes, they inhibit viral entry into the cell. Viruses need to move from the early endosomes, abbreviated EEA1, into late endosomal lysosomal protein, abbreviated LAMP1, in order to be released into the cell. And this step is pH dependent. I have a graph from a recent publication showing untreated cells, chloroquine-treated cells, and hydroxychloroquine-treated cells, and where viral proteins were localized within the endosomes. You can see that chloroquine and hydroxychloroquine held viral proteins inside of early endosomes and prevented them from reaching late endosomes. This would also help to prevent their infection of cells. Some additional actions of hydroxychloroquine and chloroquine. They enhance zinc uptake into cells, which helps to interfere with RNA polymerase. They can also inhibit glycosyltransferase enzymes, and it's glycosylated ACE2 receptors that are the entry site for severe acute respiratory coronaviruses. And finally, they inhibit the clotting cascade and platelet aggregation, which is beneficial in patients with COVID-19 because they can have hypercoagulation as a late manifestation of the disease. Now, some words about pharmacokinetics. I have each drug on its own slide. Hydroxychloroquine is first. For absorption, it's well absorbed with 70 to 80% bioavailability following oral dosing. It's distributed very widely throughout the body with a large volume of distribution of 47,000 liters. This is because it can bind to cellular components of blood, including platelets, and can also concentrate in tissues such as the liver, lungs, and other organs. It is metabolized primarily by CYP2D6 to the active metabolite des-ethyl hydroxychloroquine, and it has a very long elimination half-life, 537 hours in blood, which is the same as 22 days. And the active metabolite is an even longer half-life of 40 to 50 days. These compounds can both remain detectable in urine for months after treatment is stopped. Chloroquine has similar pharmacokinetics to hydroxychloroquine, 89% bioavailability, plasma protein binding of 60%, an even larger volume of distribution at 65,000 liters. It's metabolized also by CYP enzymes, but different ones in this case, 3A45 and 2C8, and has two active metabolites, des-ethyl chloroquine and bi-des-ethyl chloroquine. The half-life of elimination increases with dose, and two examples are following 250 milligram dose, 3 hours, but following 1,000 milligram dose, 300 hours or 13 days. Again, detectable in urine for months. Because of these properties, the large volume of distribution in particular, pre-analytical factors are a concern in the analysis of hydroxychloroquine and chloroquine. Keep in mind that the mechanism of these drugs includes being sequestered in red blood cells. Chloroquine can also absorb to glass, so it should be collected and stored in plastic. And because of this tendency to sequester in red blood cells, the blood concentrations tend to be higher than those in serum. You can also get irregular serum recovery depending on how long you clot the sample and what speed you centrifuge it at. So it can be more straightforward to interpret blood reference ranges if they're not collected by the same study parameters as the reference range. The blood to plasma ratio is also high at 5 to 10. Postmortem blood concentrations in non-toxic cases overlap the concentrations reported in fatal cases. That's not uncommon for drugs with a large volume of distribution, and it makes it difficult to use a final postmortem concentration to interpret whether a dose was toxic or not. It may be due to postmortem redistribution of these compounds. So just note to interpret postmortem concentrations with caution. For specimen handling, these compounds are both remarkably stable at room temperature in a variety of fluids. It's also possible to analyze chloroquine as a dried blood spot, and that can be kept at room temperature for 1.2 years with desiccant and maintain a similar concentration as when it was originally collected. Analytical techniques are reported in a great variety and abundance since these drugs have been around for many decades. LCMS has two references here, and you can see the measured range usually starts close to 10 or 20 nanograms per milliliter. Most of these methods are in whole blood, and one of them in capillary blood for sampling smaller volumes. This is, again, because it's easier to interpret concentrations in the whole blood matrix since you don't have to account for the variability of recovery following clotting. There's also a method called turbulent flow, LCMS, that's used for whole blood analysis. And two different screening techniques, GCMS, a mainstay of forensic toxicology, and LC-TOF, time of flight mass spectrometry. Chloroquine, being older and perhaps not as commonly encountered today by forensic toxicologists, does have some publications even in recent literature. An LCMS method for analyzing whole blood plasma and dried blood spots. Similar lower limit of quantitation to what we saw for hydroxychloroquine, about 10 or perhaps slightly lower than that, nanograms per mil in blood. Spectrophlorometry was also used in the 1970s. GCNPD can be used as a technique for quantitation. And LC time of flight mass spectrometry is also effective at screening for chloroquine. If you happen to identify these compounds through screening and are able to get a concentration, it can be interpreted with caution against published reference ranges. It might not be likely to detect them with general unknown panels, however, so you might need to look at case history to determine which samples should be sent for quantitative analysis. The concentrations for therapeutic use of these compounds are both similar. 200 nanogram per mil is the average concentration in responding rheumatoid arthritis patients for chloroquine, and 200 is the cutoff for non-adherence in lupus patients. Both of them have a therapeutic range around 400 to 500 nanogram per mil, but note that the therapeutic ranges for chloroquine are being reported in serum in this case, so they could be very different in blood. Hydroxychloroquine concentrations are reported in blood. And high therapeutic concentrations tend to be about 2 to 3 times higher than those average concentrations with therapeutic use. In non-fatal overdose, hydroxychloroquine concentrations as high as 26,000 nanogram per mil in serum have been reported. That case did require resuscitation and involved a 36-hour coma. Postmortem non-toxic and overdose ranges were also reported, and you can see the overlap there where non-toxic concentrations can be as high as 39,000 nanograms per mil in blood, while postmortem overdose can be as low as 20,000. Similar thing is seen for chloroquine, with postmortem non-toxic as high as 14,000 nanogram per mil and overdose starting as low as 3,000. It was actually recommended by one publication to use liver for interpreting chloroquine postmortem. 150 milligram per kilogram was established as a threshold for overdose. In summary, hydroxychloroquine and chloroquine have diverse mechanisms and may cause a spectrum of adverse effects. These can include cardiac arrhythmia, retinopathy, lowered seizure threshold, and blood dyscrasias. Medical conditions as well and drug interactions increase the risk of adverse effects. These can include glucose 6-phosphate deficiency, drugs that increase the QT interval, such as digoxin, drug interactions. Infants and children are also known to be more sensitive to toxic effects. And finally, blood or plasma should be collected in plastic tubes and compared to a matching reference range or normalized with the blood to plasma ratio in mind. And consider liver concentration for postmortem interpretation. In my last slide, I have included several resources for further information. There are many different drug interaction checkers on the internet. Some examples are here. The benefit of the interaction checker is that you can enter multiple drugs that are found in a case and see if they interact with each other to cause side effects. For example, entering azithromycin with hydroxychloroquine will give you an indication of a moderate interaction because both drugs can extend the QT interval, making them arrhythmogenic. Some government resources include Daily Med, which is a great way to search for full prescribing information using either the brand or generic name of a drug. The drug information portal is very useful if you're uncertain of the spelling of a drug. So it might have been transcribed incorrectly by somebody at a crime scene, and you can put in a misspelled drug name and the drug information portal will give you a list of the best matches. It also links to Daily Med. The clinicaltrials.gov page includes international trials as well as US trials. At the moment, there are 79 active studies for hydroxychloroquine, including the keyword treatment of COVID. And finally, FDA, that is a great site to go to for history of drug approvals and current status. You can also subscribe there to updates for recalls and safety alerts. That's the end of my presentation. I thank you for your time, and I hope you enjoy your education experience at Labroots.